So first and foremost, I'll start with the team right here. I'm seated at Ministry of Health within the Office of the Assistant Commissioner Health Promotion and Education. It's because we couldn't have the National Eye Coordinator, Dr. Stanley Bubichire, available today because he's on leave until 31st of this month. But Mr. Cassim Ddumba was delegated, and I will ask him to talk to us. Here he is.
Hi everyone, called Cassim Ddumba. I'm the Technical Officer for Advocacy, Communication and Health Promotion and Social Mobilization for the health intervention in the Ministry of Health, especially immunization, eye care, disability, nutrition, and school health.
Yeah, thank you very much, Mr. Kaggwa. I will also introduce myself to those who have not seen me before. My name is Dr. Henry Muwonge. I work with Uganda UK Health Alliance. I'm currently the Chief Operating Officer. With our role of doing coordination, that's how we came up with having this platform where we are going to share learning and we are going to discover opportunities within this country through Mr. Ddumba. So I'll go to the next person, Primrose Magala. I've mentioned your name. Please go ahead and introduce yourself to the team. I think she can't hear us. Can we have any other person introduce themselves? The next person there, Terry.
Yes, hello. How are you?
We are fine.
I think you can. I guess you can hear me from your response.
I hear you very well.
Clear.
Okay. Okay. Well, thanks very much for inviting me to the meeting. Let me just spend a minute or so introducing myself and my and our involvement in Uganda. So my name's Terry Cooper. In this context, I'm the project manager of the Vision 2020 links. In this case, between the Royal Free Hospital here in London, from where I'm talking, and the Malago National Referral Hospital that I know you all know well. So our link has been established for 7 years now. This is the 8th year, in fact. And the team leader, and she does send her apologies for not being able to join us, but she had a prior engagement, is Claire Davey, consultant ophthalmologist, retired now, but had worked for many years at the Royal Free Hospital here in London. And our link focuses on education and support of our colleagues in Malago. Clinically, we support the area of diabetic retinopathy, diagnosis and treatment, and also childhood cataract. We also have a leadership development program that's been going for a couple of years now, which has been quite successful. So over the 7 years, we've visited Malago a minimum of once, sometimes twice, sometimes 3 times a year, a team from London. And we've also hosted people from Malago to come here to London to see what we get up to here. Although recently we've had issues with visas that meant that activity has reduced. But perhaps the most exciting thing to mention today is that back end of last year, we received a large grant from THET, who I think you know. THET is the Tropical Health and Education Trust, again based here in London, and they are funding a project which is about community eye health. So it's basically will be a series of workshops in Kampala, Jinja and Mbarara, and those workshops will take place in March, and we expect up to 50 trainee ophthalmologists, OCOs and ophthalmic nurses to attend, followed by in-field community eye clinics in the Kampala and Mbarara areas. We expect 50 clinical participants in the workshop, and we expect to see and screen up to 500 patients as a result of that. And that's a pilot, and we hope that it will follow on with a larger project next year to roll that out across Uganda and the COEXA countries.
Sounds good.
So that's me.
Testing. Testing 1 2 3. Can anyone hear me?
Yes,
I can. Yes.
Hear you.
Okay, very briefly, I'm Ian Young. I'm a medical retina fellow, an ophthalmologist at Moorfields Eye Hospital. I work with Primrose. I apologise, I'm obviously having a working lunch, but nothing to report. I know Henry, I know Primrose, I know various people. What was I going to say? Yeah, so I was at Ddumba only back in November, Primrose and I, and at the moment, that's it. Nothing else to report.
You did a brilliant
Wow.
job.
Thank you very much, Ian. So can we hear from the next person? Dr. Noami, can you hear us now? Dr. Noami, click on, there's a pop-up there. There's an instruction which tells you to click join by audio. If you click that, then you'll be able to speak to us. I don't know. I'll just send her a message. Denise.
Yes.
You're welcome, please.
Can you hear me?
We can hear you very well.
Oh, well, good afternoon to everybody.
So yes, it's an introduction session, so just introduce yourself. We shall go ahead and do an overview of what you're doing later.
Right. My name is Denise and I'm a social worker by profession, and I set up a small project in Ginger called the Site Restoration Project, so that some children could receive eye care. And Primrose Magala from the Moorfield Hospital joined us in our project, and some of the children from Ginger have actually been screened and treated when Primrose was over there. What we found from the small project, because we couldn't get any of the eye organisations to these children because they didn't have a project in Ginger. So this is how I started it myself with Sebastian, who runs an organisation for the parents of disabled children. So we worked with a local optometrist called Preamble, and she's been screening the children in groups of 10. And we found that the children, we've held now 6 eye camps, but we found that the children, it falls into 3 categories. One, those easy to treat with drops or glasses, spectacles. Those that need operations that are fairly straightforward, like cataracts, and the group that need very complex surgery, like, transplant. We've actually been funding these eye camps through the charity Helping Uganda Schools. So do you want me to say any more? So I'm actually very passionate and interested about eye care, particularly because children can't go to school because they can't see. Sure. And if they had treatment, then a lot of these eye conditions would be eradicated.
Yes, thank you very much, Denise. That is actually very impressive, especially the fact that you're passionate about eye care, and especially in children. And we are going to have a session where we are going to share more. This is just an introduction session. So thank you very much for now. And I will ask Dr. Noami to speak to us if you're able to. Dr. Noami, are you able to hear us now? Dr. Noami?
Okay.
Yes, I can hear you. We can hear you.
Okay, now I'm Naomi Nsubuga from Brien Vision Institute, based here in Kampala, Uganda. And we're working in care projects across, I cover the East Africa region, Kenya, Tanzania, Uganda, and we did some work in Ethiopia and Eritrea. But primarily right now I'm working in Uganda and Tanzania. We've done projects on comprehensive eye care training. We're a technical NGO and currently working a lot on children. We've had Child Eye Health Project. We have started a training program in Magala for optometry, the first one in the country. Our first graduates are finishing this year, graduating next year. And we've trained mid-level eye care workers, the OCOs as well. Provided equipment, infrastructure, support, as well as training materials, books, and open up a optical workshop to make glasses, train the spectacle technicians, as well as open up a vision center for Magala University, where they'll be checking, the students will be checking eyes of the students, as well as people in the area around Magala. But they also do outreaches.
Thank you very much for the support.
Yes, thank you very much, Dr. Noami.
Welcome.
Are we still in touch? Yes, we are still in touch. So there's, I think, one person who has not introduced themselves, and I think that must be Primrose. Primrose, are you able to hear us now? Hello, Primrose. So sad we've not yet. I think there's a technical problem, but I think we shall go ahead. Isaac, can you please just briefly introduce yourself within 1 or 2 minutes? Isaac? Isaac? Isaac?
Yes, my name is Isaac Chigozi. I'm the founder of the proprietor of the I Foundation. We've conducted different camps throughout the
I think
Jinja, Masaka, Ala, conducting different I camps. We have been working with originally from Luelo. I'm also the executive.
Isaac? Hello? Are the rest hearing us? Okay, I think Isaac's
Yes.
sound is not really stable. I think we shall move on. With our agenda, I'll project it right here so that everyone else can see it. So that we focus on what we are, why we've sat in this meeting. Isaac, are you back? Okay, I'll just project for you the...
Yes, hello, can you hear me?
Yes, please go ahead. We can hear you now. Well, I think Isaac's signal is not stable, and I'll request that we go on. He will, maybe when he stabilizes.
Henry, can you hear me?
Isaac? Yeah, we shall give you an opportunity to speak maybe later. But to keep time, let's, I think, go through briefly the proposed agenda. Is everyone able to see the agenda that I have just projected?
Yes.
Yeah.
Yes, now the proposed agenda, we have an introduction which we've done. We shall do opening remarks that I'll give, an overview of the National Eye Health Plan by the Minister of Health. In this case, it is Mr. Kaggwa who is going to represent, and is going to present that. Then we shall have a discussion amongst us as partners, of course, considering what each and everyone is doing. And then we shall identify some opportunities where we can jointly work to support the agenda, the Minister of Health, in advancing eye care, and then we shall close the meeting. So I'll dive straight away, right? Since we've finished with the introduction, it's unfortunate we can't hear from Primrose. Primrose, are you able to hear us?
Yeah, can you hear me now?
Yes, we can hear you. Please go ahead and introduce yourself to the team. Very happy to hear
Hi,
you.
hello everybody. I'm Primrose Magala, and I'm part of the Eye Project Uganda, and I'm part of now everybody working in the Eye Health Consortium in Uganda. So we're all a team.
Welcome, Primrose. Thank you very much for that brief introduction and precise. So I want to go ahead with the next item on our agenda, which is opening remarks from the Uganda UK Health Alliance. And I'll give that. I introduced myself earlier, and as we've mentioned, for those who have not known so much about the Uganda UK Health Alliance, I'll give just a brief overview, a very quick preamble about the alliance. Uganda UK Health Alliance started in 2013 as a collaboration between the Ministry of Health Uganda and NHS Health Education England. It was started as after signing an MOU between the Permanent Secretary by then of the Ministry of Health Uganda and the Director of Global Engagements Health Education England, currently Professor Jed Ban. And it was set up to support the government of Uganda in building capacity of the health professionals, especially through exchange of professionals like volunteers from the UK coming to Uganda, and also supporting the movement of Ugandan professionals back to the UK to build their capacity, expose them, and for observership in order to support the health professional training. It was also set up to better coordinate UK-based organizations in Uganda working in the health sector because there was a recognized gap that all these organizations working in the health sector in Uganda are doing a very commendable job. They are doing it very well, but most of the time there is lack of coordination, and as a result, there is a lot of duplication that comes along. So because of that duplication, we end up having not to realize our value for money. So when we do coordination, we reduce duplication and realize the value for money. So it was also set up to find alternative mechanisms of funding within the health sector, as opposed to the donor funding that is always focused on by most of the governments and currently within our government. So those are the things that why the alliance was set up. So currently we have an operational model where we have programmatic areas on which we deliver all these we're talking about. The programs are human resources for health. We have a program on health financing and investment. We have a program on clinical services. We have a program on health leadership and governance. And amongst the programs, the reason why we are sitting today is the program of clinical services. In clinical services, we have consortia that have been formed. Actually, in each of those programs, we have consortia of member organizations which are working towards achieving a particular goal, but through supporting the government of Uganda. And in clinical services, we have one of the consortia, which is the Health Consortium, and one of the reasons why actually we have gathered today to have this kind of gathering and sharing. So the core values under which we operate are shared learning, joint working, and co-development. We realize that the current model of approach to international support should be through joining efforts and not just individual efforts. Because if you join efforts, you achieve better than if you come and do as an individual, as a single organization, or if you work in silos. So that's why the alliance was formed by these two governments to ensure that there is coordination and focusing of resources. So the Health Consortium today, one of the mechanisms we thought of bringing members together is having a continuous communication platforms, and one of them we have thought of and that we've come up with is this webinar platform. So we are looking at this as an opportunity where members will share learning. Ministry of Health will inform members of what is going on, so that we focus our resources on the agenda of the ministry. I want to upload iProject Uganda and Brien Holden Vision. Actually, everyone, I think, even Vision 2020, all the work that is being done is actually towards supporting what the Ministry of Health is intending to do. The iCamps that have been organized by iProject, iCare Foundation, Vision 2020 has a grant. They are going to do training, capacity building. Brien Holden Vision is doing some work within the Midwestern region. If I've not forgotten, Dr. Noami will correct me if I've said it right. And also having optometrists trained within the university. iProject Uganda is supporting ophthalmologist training. So we are doing a lot of work in that line. And we just want to remind ourselves and refresh ourselves on all this, and then come up with some ideas where we can deliver all together. With those few remarks, I want to thank everyone, and I want to say that you're welcome once again, and I want to take this opportunity. Before we respond to my remarks, I'll give the opportunity to the Minister, Mr. Kaggwa Ddumba, to speak to us, and then we shall have reactions and discussions thereafter. Thank you very much, everyone. I wish you fruitful submissions.
Yeah, thank you very much, Mr. Muwonge, and everyone. I will start by thanking you very much for the supplemental efforts you are giving to our ministry, our country, and I would like to present to you the National Eye Care Plan. But before that, as I already said, I'm called Cassim Ddumba, and I am an Advocacy, Communication and Social Mobilization Technical Officer within the Health Promotion and Education Division. Health Promotion and Education Division is a support division to all health service delivery in terms of community liaison, education, and promoting health. Our plan, this is the fourth plan that has been developed by the ministry, and it was developed based on the WHO Global Action Plan of 2014-2019, and focuses more holistic approach, addressing all the preventive, promotive, and curative and rehabilitative eye care services. But here I will stop a bit and observe that most of the interventions I've seen on eye care have been mainly curative. And I think we need to refocus or redirect our efforts to preventive, because some of these eye conditions, I'm sure, are preventive. They can be prevented by some simple practices. But most of the interventions that I've come across have always been curative. The eye care camps are always curative. I really feel glad, because if it has already happened, they have to be corrected. So the corrective efforts are also commended. But I think as we discuss, we should really focus so much on the preventive side. As you see, the health sector development plan lists blindness among the burdens of the non-communicable diseases. And trachoma is among them. And trachoma, we know very well that if we really improve hygiene and hygiene, and it can really be prevented. The plan presents strategies to reduce blindness and the visual impairment. The achievements of the third plan include the following. Ophthalmology services have been expanded to 70% of the regional referral hospitals in Uganda, and we have developed the sub-specializations in pediatric surgery and initiated refraction services in rural district hospitals. And the bachelor's degree, as already talked about, has been established in Magala University on optometry, and the ophthalmic clinical officers intake has doubled over the year. And then Gulu Referral Hospital and Mbarara Regional Referral Hospital departments have been constructed. The gaps that we can look at are lack of emphasis on preventive, as I've already said, and promotive, and as well as rehabilitative services. So we need really to look at that so that we can prevent this from occurring. And then eye health, not fully integrated in the district health services. When you look at the DHT, the district health teams, there is nobody focus person for eye care. It is only the health educator who belongs to health promotion and education who has to look at all that. But we need really some professional eye care, eye health care person to be a focal person for eye care at that level. And essential diagnostic and surgical supplies still lack. Uganda is still far below the global standard of eye health workers per population. When you look at our data, which is also lacking, we have only close to 45 ophthalmologists. And yet, with Vision 2020, we require at least 141. So, but with this fourth plan, it plans to increase by 25 so that we can have a number increased to 70 at least. Then the HMIS data not used to advocate for advocacy. We have utilization of data, and I care as an aspect is not very much looked at in our HMIS, so we need to really improve that. Low attainment of global indicators. For example, cataract surgical rate is of 400, which is way below the 2000 for sub-Saharan Africa. The strategic objectives of this plan include to strengthen eye care services at primary, secondary, and tertiary level, and then to promote equitably distribute motivated, skilled health human resource or health workers for high care. And we still have very few. And then to promote availability of equipment, essential medicines, and diagnostic devices so for the eye care. So we need to look at supporting these strategies if we are to reach somewhere. To promote use of HMIS and research for evidence-based planning and resource mobilization, including advocacy for improved quality and efficiency of eye care services. So we need to promote that. So if you come with some support, let us support the HMIS and some research so that we can have evidence-based interventions. To strengthen coordination, effective partnership, and leadership for eye care. Coordination is very important here because many organizations come with specific objectives and targets, and then we fragment our efforts and end up even duplicating some of the services. So if we work together, probably this one would be limited. And then blindness prevention, we would like it to reduce from zero. The prevalence of blindness should be reduced to from 0.4 to 0.3. And cataract surgical rate should be increased to from 400 currently to 750 per 1 million population per year, so that we can really have those corrective interventions of these burdened people. Uncorrected refractive errors among adults beyond 50 should be reduced to from 90 to 70. And vision screening of 500,000 school-going children between 6 and 15 annually. We need really to do the screening should be done early enough for early diagnosis, early detection, so that this we reduce complication. We minimize the complications of these problems. Yeah. Trachoma follicular in children aged 1 to 9, we need to reduce it to less than 5%, and reduce the trichiasis burden to less than 1 per 1,000 of total population in endemic regions. The strategic interventions we look at strengthening outreach and static clinic cataract surgeries, and then child eye screening, refraction, and surgery, and then early identification of cases for proper intervention. For example, promotive, preventive. So we need to really prioritize the preventive part to avoid eye impairment. Then development of subspecialization services further. We have reached somewhere, but we need to develop it further. Then increase the number of eye healthcare professionals through training. I'm glad that most of our partners are talking about human resource development and training. I thank you for that. Let us try to continue to increase the numbers of eye care professionals. Then expansion of the career path for eye healthcare professionals for motivation. Because if I train as a ophthalmic clinical officer, what are my climbing ladder? Because most of them are static there. We need to advocate for their motivation by creating some ladders for them to develop further their careers. I think that's what I wanted to share with you in brief. That's the plan. That's what the plan is all about. Yeah, I think I take back the microphone to our coordinator here, so that you can open the discussion.
Thank you very much, Mr. Kaggwa, Ddumba. We appreciate you for that presentation. And I think everyone who is online has managed to listen to what the National Eye Plan is. So what he presented is what the National Eye Health Plan is in the next 5 years, between 2016 and 2020. And we also have Vision 2020, which is also aiming at 2020. So we are having two strategic plans, which we are looking at, that are guiding us. And amongst them, in the perspective of the Alliance, I want to say that at least I have looked at the fact that there is interest in increasing the outreach and clinic cataract surgical rate to improve it. And we are having many partners who are interested in this. We have Eye Care Foundation, which has done a great job and are keen to do more. Eye Project Uganda, keen to do more. Terry Cooper with Vision 2020 are also aiming at doing more education and other things. So we are really happy about that. And this moment, following our agenda, to save time, I would want us to dive straight into a discussion. But given the Alliance's perspective and what we are aiming at in this meeting, we need to be discussing, but while focusing ourselves to some of the activities that we think we can deliver on together as a team, and looking at the interests. I'm seeing some common interests already. So if we can think about bringing efforts together, that would be very good. And specifically, I would want us to focus on eye camps if we have interest, and perhaps draw a schedule which is annual and all that. Yeah, thank you very much. I want to take this opportunity to open up the discussion and to get reactions to the remarks that have been given and to the presentation that has been made by the representative from Ministry of Health. Thank you very much. So our discussion is open. You have anyone who wants to speak can unmute themselves, or you can send me a message. I can unmute you so that
hello
from you.
Hello. Henry, can you hear
yes
me?
Yes.
Can you hear me, Henry?
Yes, Ian.
I've just got very brief thoughts on this. I think, principle, I think everything's fantastic. I, fully support everything, etc., etc. Broadly, I can see that the way we're going to deliver this, I think, obviously comes down to money and resources, like all things.
Yes.
So obviously, money will come from somewhere, and in terms of resources, there's obviously an equipment thing, which is money and getting stuff, and that's fine. But also there's a human resources component, which is obviously quantity and quality. Obviously you want to increase quantity of staff, and you also increase the quality of staff. Now, the only point I wanted to raise is obviously in terms of increasing the quality and training of staff, theoretically, certain skills are currently not available in Uganda, because if they were there, they would be there already. So therefore, the only way you're going to get these skills is logically from abroad. So therefore, logically, using the analogy of if the mountain won't come to Muhammad, if Muhammad won't go to the mountain, then the mountain will come to Muhammad. So I'm proposing that, just talking out loud, that two logical possibilities to increase the quality, effectively, the education of your staff. Either you bring foreign experts to Uganda and then they spread the word, or you take Ugandans out of the country and they soak things up from abroad. I propose, broadly speaking, we do option 1, and then in some subspecialized roles we do option 2. Because if you bring foreign experts to Uganda, you teach a larger number of staff. You teach more staff for the same amount of resources because there's more people to sit there and listen. I propose it's only in very rare subspecialized, super subspecialized aspects that you need to take the person out of Uganda to learn things. And the best example I can think of that would be a vitreoretinal fellowship. I understand that there are currently only really 2 vitreoretinal surgeons, and there isn't a single neuro-ophthalmologist or orthoptist in the whole country. And so for the development of really, really subspecialist stuff, you have no choice but to take 1 or 2 chosen people out of the country, take them somewhere, England, America, any like, and get them trained up appropriately. But I was just talking out loud as to broad principles, how to deliver the training you want. That's it.
Yeah.
Thank you very much, Ian. Very brilliant ideas. I'm really happy about the fact that you've talked about the first point is about funds, and that's true, vividly true even from the plan, that you see that there is need for resources, for training there is need for resources, for funds, sorry. For buying supplies within the hospitals, there is need for funds. For paying professionals and all that, ensuring that you retain them and train them, there is need for money. So I think there is need for funds, and I think as a consortium, we need to focus on that is one of the things that we need to focus on. However, I'm seeing this may not be one of our short-term achievements or goals that we may have, maybe a bit long-term, but I think it's good for us to focus on it and also consider delivering on it. We are thinking of having an eye health fund, which, of course, partners, because amongst the partners within the consortium, we expect to have, say, donor funders and then perhaps thinking of alternative mechanisms like investment. We are thinking of having an eye health institute, which can do research, and through research you can raise resources. Of course, you can inform the policymakers and the people who draw budgets so that they can focus resources there. That's one of the things I'm thinking. And then looking at the human resource quality and quantity, bringing foreign experts is a very good idea because you're targeting many at the same time. But I think getting foreign experts here also still needs resources in terms of funds. And I think as a consortium, we may have to brainstorm on how we shall do that. But thank you for your submissions, Ian. And I would welcome any submissions from any other person. Yes, Dr. Naomi. Let's unmute you first. You're muted.
I'm unmuted now.
Oh, yes. Great.
Okay.
I can hear you now.
I forgot. But I've been... Yes, I'm looking at building up on Ian's contribution. Definitely developing capacity, especially human resources, is difficult and very expensive. Training programs are very expensive. We've experienced that. And we've been trying to look at innovative ways of trying to see how we can continue. Bringing in expertise from outside is very expensive. We have been suffering that at Magala, trying to bring in expatriate faculty. It's very, very hard to sustain. We've also been looking for ways to see how we get partners to join us to support them, because when you get somebody, for example, from the US, they expect a salary close to what they're making in the US, and Magala cannot reach that. We're having to top up. So we've been providing some funding for top up, but in our optometry programs, that is one of the biggest expenses, is support of the top up for the expatriate market. So we have brought in 1 or 2, but at the same time we're looking at issues like online lectures, webinars and things like of this sort.
Sure.
And we have partnered with University of New South Wales in Australia, where we're in the process of discussing how we can do some online lectures with the optometry faculty from the
Wow. Oh, we are missing very brilliant ideas from her. Dr. Noami, we are losing you. The signal seems not stable your side, but I would request the rest to go on. Maybe Dr. Noami will give us her submission when she gets a more stable signal. Any other contributions from any other participants are welcome.
This is Terry. Is it possible to say a few things now?
Yes, we can hear you. Who is that?
This is Terry.
Terry, yes, please go ahead, Terry. Yeah. We can hear you.
Okay. Okay, and I hope not to take up too much time, but first of all, thank you very much, Cassim, for that overview. It's extremely interesting, and for us, the fact that you've mentioned specifically prevention rather than cure really fits in well with our thinking. But just a few comments, and what I have to say is I've only been coming to Uganda for 3 years now, and I certainly came to the conclusion that there needs to be some way of joining up all of the various initiatives that are going on, and you've done that. So thank you very much for that. One suggestion I have, following on from Ian's contribution about how to move forward is, and maybe this already exists, I would appreciate the possibility of there being a mailing list that I could subscribe to, so that I could, in a very simple way, share some of the projects that we're working on with other people. Because I'm conscious that at the moment we're enrolling for our workshop program, which is in March, as I've already mentioned. And I'm sure that would be of interest to people around the table and the organizations that they represent, but maybe they haven't seen or heard of it yet. So that's one request, is whether there's a way of joining everybody up in an email list, which may be the simplest thing to do.
Okay.
Yeah.
So that's a request. A couple of other things that, and again, I want to offer my services. I'm currently spending perhaps 2 days a week of my time working on projects related to Uganda. And as well as running the Vision 2020 Links program between London, Royal Free and Malago, some of you may know I also have a background in ophthalmic equipment, and I've run 2 courses or 2 workshops in Uganda already on care and maintenance of equipment, and we know that equipment is key to serving our patients, but often it doesn't work, or it's broken, doesn't get fixed, etc. And I feel that I can, and we can make a difference there using this workshop program. So that's something I can offer. I should also say one of the things I do is I'm a photojournalist, and many of my pictures and material has been used by the IAPB and Sight Savers to promote of the programs and highlight some of the issues that we face. So again, I'd like to sort of offer that service to people around the table, and they could contact me, and we could come up with. I personally will be in Uganda 4 times this year. The first time is beginning of February, and I'd certainly welcome the opportunity to meet with Cassim and other people in the ministry, because I'd like to share with you what our plans are, because ultimately one of our objectives is to try to establish a community eye clinic protocol that could be taught and rolled out across Uganda and East Africa. They're my main comments, and again, appreciate being involved in this webinar.
Well, okay, thank you very much. Yeah. Thank you very much, Terry. Actually, your requests have been all noted, and I think this is very important and gives us actually an idea into what our next steps should be, because we've already been thinking about this, and we had wanted it to come out from the participants of the webinar. One of the things is a mailing list, and I would say as the Alliance, we are very keen to set up what we call a sub-community of practice, we already have a community of practice, which is also a mailing list where partners can post whatever they post, but the other one is too general. It's not focused on eye health. So we are planning to set up, and I think this is one of the things we are going to do right here, because I think the rest of the team would endorse to that. We are going to do it right away. We have an IT person who can do that for us, so that we have a user-friendly platform where everyone can be able to post what they are doing, what is going on within their projects, and what our next plan should be, and also to know what is happening back these ends in the Ministry of Health. And then the other bits you've talked about, ophthalmic equipment training, I think is a very important component here. We see that sometimes we may, equipment comes into so many facilities here, but some people do not know how to use them. And at the end of the day, we have the equipment, but the service is not being given. So it would be a very great contribution from you. Even as we move out, the rest of the team moves out, say for these eye camps, we can arrange maybe some training sessions where you can have some of these trainings done, and then pass on the knowledge so that we ensure sustainability. The team we train here trains others, so we do a kind of a training for trainers. Yeah, and then being a photojournalist, I think, is a great opportunity for publicity of whatever will be being done right in this kind of platform. The eye camps usually need publicity. Whatever work is going to be done needs publicity, and having you on board is a good opportunity. Meeting with Minister of Health, Mr. Kaggwa is here. He's going to take back the information to the department. He just represented Dr. Stanley, because Dr. Stanley is on leave, and he'll be able to take back that information, and I'm sure.
But you're most welcome. Please come. We shall work together.
Great. So thank you very much, Terry, and we welcome other comments, questions, compliments from any other participants. You're welcome. Dr. Noami, we lost you, and you were still saying something. I don't know whether you've managed to come back.
Yeah, I'm trying to, I think I'm back.
Yeah, yes, you're back.
I'm trying to find alternative. But yeah, ways of it. I'm sorry I missed the last part. I don't know exactly where I got lost.
So we lost you when you were still talking about the fact that use of as alternative mechanisms to training. Alternative mechanisms of training using webinars and online platform. That's where you ended.
And the relations with the Australian colleagues, partnership. You were talking about that.
Yes.
Yeah.
Okay. All right. Yes. We formed a partnership with Magala University, Brien Institute, and University of New South Wales in Sydney, Australia, to again for support in faculty support, ideally, but of course the expense of flying somebody from Australia is very high, and university also doesn't have facilities to house them. So webinars, online video conferencing facility, their public health lectures with so when we look at that availability of that technology, we thought that we could be able to use that. And then spend a little bit of money bringing somebody in maybe for the practicals for a short term versus bringing somebody in for long term to lectures. So those are the things that we are trying to work on at the moment. As far as funds, like I said, it is quite expensive. Eye care does not get much funding, as you are all aware, compared to some of the other conditions. And most of us enjoy competing against each other, so it makes it very difficult to get some funding for that. But looking at partnerships, again, is key. We've partnered with Light for the World at Magala, where we shared the equipment. We brought in the equipment for the teaching clinic, as well as setting up a vision center, which we both jointly equipped. We responsible for the curriculum.
Okay, we've lost
as Brien Holden, technical side, and looking for opportunities. Skills are key, and the challenge you have in Uganda, for example, we're only 2 optometrists. Am I back?
Yes, you're back. Please go ahead.
Can you hear me?
Yes, please.
Yes.
Okay. I think Dr. Naomi's internet is unfortunate, actually. She has very brilliant ideas, and I think her signal is not really that good. But it's okay.
Can you hear me?
At least we've picked the points. Yeah, we've heard that you're talking about alternative training.
Mr. Kaggwa's presentation. The presentation on the strategic plan.
Sorry, I think we can't sustain her signal, and I would give an opportunity to any other participants to talk. Maybe Dr. Naomi, when she comes back, she will pick up from there. But at least we've picked some 2 points from her. She's talked about alternative ways of training, especially if we are to use foreign experts, using online platform, or utilizing technology like we are doing right now. It minimizes a bit of resources. And I think that's a very good idea. She has told us it has worked for them as optometrists in their training. And then she has talked about partnerships as being a means for resource mobilization, joining efforts to avoid that competition, so that the little resources that are there for eye care, especially the funds, are focused and are used jointly. Yeah, those are the 2 things I managed to pick from her. Maybe we can get submissions from any other participants, comments about the presentation, about whatever is being discussed right here. Primrose, do you have anything to comment on? I can unmute you. Yes, someone is saying something?
Hey, Denise.
Yes, Denise, please go ahead.
Can you hear me? Thank you very much for everybody who's spoken today. It's really enlightening and very satisfying to know that so much help is being given through the Uganda Health Alliance for the children. Just a couple of comments. Mine is a very, very small project, and I found from doing this quite a lot of children are assessed but never treated because the parents cannot afford to buy the spectacles or buy the eye drops. Then children seem to be going through a process of assessment and reassessment, but not actually getting treated. And I'd just like to know what can be done about this. I mean, again, from my own limited knowledge, it would seem a central place, like a shop in Ginger, that would be testing the children's sight. Many of the children could actually be treated at the primary care level. I'm finding that there is quite a lot of money wasted. Also, what I found from my small project is it's very difficult to find pathways to the secondary services for the children to be treated. And I think if the UK Health Alliance could do something about that, that would be really helpful. And I completely agree with the speaker who spoke about preventive work. I think this is a great challenge. But if there were more outreach workers regarding educating the children, then we would see less children with eye problems. Thank you.
Thank you very much, Denise. Well, I will comment mainly about the issue on children finding it hard to find secondary services. Especially, I think, when you want to get services, say from super specialized services, say from Mulago. Now, in the short term, yes?
I was just going to say, sorry to interrupt you, but I thought it might be nice for the people there to know that the charity Help Uganda Schools is actually funding the training of 6 optometrists.
That's great. That's great.
So we're actually, our charity is actually doing that. So we are adding into the special event, because I know you're very short of eye specialists in Uganda.
Mm. Oh, thank you very much. So that is an additional point. That's a very great, very great contribution. Very good contribution to this plan, like you've seen it. And like I said, I would just want to give a small contribution towards the fact that children, especially in Jinja, find it hard to get secondary services. We were supposed to have Uganda Red Cross Society online so that we can hear from them, because as the Alliance, we are aiming, we are not an implementing entity, but we are trying to look at coordination of those, because we know there are very many partners who are doing some work somewhere in regard to what you're talking about. So we would want to have them on board so that we combine efforts, we complement each other. If Helping Uganda Schools has identified the ones who have the need, and then need services, say from a super specialized institute, facility, Semulago, Omengo, if there is someone who can link up there, and we're thinking Uganda Red Cross Society would be in a very good position to do that. Only that I think we've not been able to have them today, but when we get grab of them, we shall be able to exchange and see how they can help, because they do a lot of humanitarian work, especially transportation of those who are marginalized and are not able to access service. So that's an idea I'm thinking about, Denise.
Yes.
On the Alliance's perspective, yes. And then outreach for education and all that, we are seeing Terry Cooper is going to do a lot of work in regard to that, and I think that will help us and will support this kind of work to achieve the prevention. Yes, someone was calling. Any other person with any other contribution? Yes, Primrose.
Yes, Henry.
Yes.
Can you hear me?
Yes, Ian.
Yeah. Sorry, I just wanted to say I'm really sorry, but I've got to get on the tube to get to work, so I've got to go. So you guys have a good meeting. I'll catch up with Primrose later. Really sorry, I've got to go to work.
Yeah, we shall share the feedback on email, and this video will be shared actually with everyone else.
And I'll catch up with Primrose. I'm sorry, I've got to go on the tube. All right, thanks. Cheers. Bye.
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 Okay.
Bye. 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 Bye.
Can you hear me, Dr. Henry?
Yes, we can hear you very well, Primrose.
Wonderful, wonderful. Thank you so much, everybody, for your contribution. What I wanted to add is we seem to be doing something. Yes, we have so many challenges, but what is possible right now? And I think what's happening is we just
We seem to have lost Primrose. Is anyone else hearing us? Primrose?
Yes.
Yes, you're back. Primrose, continue.
Yeah. I just wanted to mention, for example, we have these things happening. Number one, we've got a camp coming up this weekend. The Uganda Eye Project is contributing to the training of 5 ophthalmologists. We're also trying to get some nurses trained up and perhaps follow a nurse practitioner ophthalmic pathway. So we are doing bits and bobs, but what we need to know is what else is happening from the members. And I think that's what I would like to take away today. For example, we also have a consultant who's ready to teach our postgraduates on vitreoretinal surgery. He's planning to come in October, but we don't know yet is, has it been agreed by the site providers? You know, those are the things we need to kind of agree on today, if possible. And then most of us can then add to those projects that are currently taking place whilst we find the sustainable long-term solutions.
Thank you very much
So,
for submissions.
Yeah, I would like to, now that we've got the Minister of Health on board, I just wanted to know whether, is there something that can be added to what we're contributing, and perhaps that can then go to UUKHA, who can hold the funding pot. A very good example is that the postgraduates that we're supporting have just completed their first year, so we're busy gathering another £5,000 for their second year tuition. Is the government able to contribute to that at all? It would be nice to know that.
Yeah, thanks, Primrose. That one I have to forward that, but I'm not in the position to commit the minister about that. But I'll make a submission to that.
No, lovely. Thank you. In regards to the plans, Dr. Henry, can we all agree that the planning comes via UUKHA in terms of the upcoming camps?
Yes, now we are glad that we have a team right here with us. And
yes.
One thing I've realized is that we have a common interest in supporting eye care, generally speaking, holistically.
Yes.
But of course, like you heard from the Ministry of Health's perspective and what the National Eye Plan says, we need to focus on promoting rehabilitative and preventive services. So the preventive is the training, then creating awareness in the community, you know, the outreach clinics, moving out to those. And I think training optometrists is one of the things. Dr. Noami will add on that if she's able to say. But I think we need to look at what are the specific deliverables in prevention that we can work on. The eye camps is one of the targets, is one of the, actually the interventions that the ministry is also looking at in the national plan. Eye camps to do cataract surgeries is one of the things. And I think looking at the fact that almost everyone is looking at that particular area, I think we can agree as a team that we shall need to deliver eye camps, like Primrose is saying. I don't know what the rest of the people, rest of the participants have to say, but that's one of the things that we need to focus on and perhaps draw up a plan and a schedule of these camps so that we know when they are going to come. When we draw up a plan, we shall be able also to have a budget and get to know how much money we need to run these camps as a team. What will be the approach? Will it be regional? Will it be by district? You know, that kind of approach. That's what I would think. And I don't know what the rest of the people think, but that's one of the things I'm looking at. And of course, we shall supplement that with Terry's preventive measures that he's coming with. That's what I think.
Who needs to own that, Dr. Henry? I think that's what we need to agree on. How can we all communicate together and know what's going to happen?
Now, the Alliance is going to create a platform for communication. Like Terry mentioned, we are going to have a mailing list. And that's what I call the sub-community of practice in our major community of practice. And that will be a mechanism of us communicating. That is one. And secondly, this is just the first webinar. And we plan to have subsequent webinars because this is one of the cost-effective mechanisms or ways of us communicating and exchanging physically, interfacing as a team. So I'm looking at having a mailing list, which we've called the sub-COP, and then also having these webinars frequently. What I want to request the team to agree on, we don't want to just dictate as the Alliance, but to agree on as a team, how often should we have these webinars? We were thinking, on my own perspective or on our own perspective as the Alliance, we think we can have these webinars, say maybe quarterly, every 3 months. I don't know what the House would think about that, but that's what I would propose, and maybe the rest of the people can suggest what they think we can do. Because we don't need to have this one as a one-off. We shall have subsequent webinars to ensure that we follow up on whatever we have agreed on there. So I don't know what the rest of the people have to say other than, or maybe Primrose, what you think about that frequency of webinars.
I think the 3 monthly is good, Dr. Henry, because it gives us time to plan. Now, the other thing I wanted to ask Isaac. Isaac had mentioned the prospect of Luwelo being a site. What does the team think about that?
Isaac, I don't know whether he's still online. It would be good for him to anyway, I think he's off. He has gone off. Perhaps he also had some technical challenges. But looking at where we are going to do the camps, that's also another question that we have. As a team, we are not going to dictate. We need to agree. Are we going to Luero? Are we going to the West Nile region? Are we going to the Central region? Where should we start from? Where should we end from? That is upon the entire team. We don't want to dictate to anyone because we are not going to do this implementation, but it's the rest of the team right here that is going to help, and we shall be there to support the coordination, give the leadership and the guidance.
Henry.
Yes, John Paul.
Thank you very much, Henry, and Mr. Kaggwa and the rest of the team. Just as the members of the team have mentioned, I think it's a component of joint working, shared learning, and co-development that we are trying to factor in here. And as we highlighted that it has come out as a something of common interest from many partners, that one of the things that they want to do are the ICAMPs. Now, if I may propose that in the communication platform that we are going to set up for the Health Consortium and the sub-COP, through the aid from members who are planned, see how we can merge the interests of the various parties and non-masks plan covering the various
John Paul, your signal.
Can you hear me now?
Yeah, we can hear you, but you're not stable.
Proposing is that we can start from the communication platform. Members can propose their respective earlier planned camps and venues, and then we merge. We merge all the earlier plans that individual partners have developed, and we develop a uniform or anonymous consortium health camp plan. So in that, we shall not have developed something new. We shall not have developed something from scratch, but we shall have factored in a component of joint working, shared learning, and co-development amongst partners within their respective earlier developed activity plans. I don't know whether, have you heard that, Henry?
Yeah, we can hear that. Thank you very much, John Paul. Those are very good ideas, very good contributions. And I still would want, yes, Dr. Noami, you have something to say. Please go ahead.
Yeah, sorry, I've been disappearing on and off. Yeah, this is, since the Alliance is playing a coordinating role, it's important to liaise with the National Eye Health Coordinator, because his office knows where most of us are working.
Yes.
And I think your office needs to map and know where services are already being provided and the areas where the services are needed. Because you're going to find that what you're trying to avoid of duplication is now you're going to be creating it. Okay? Because everybody's going to wonder, I want to go here, I want to go there, but then you might find somebody's already there. So I think mapping is important, coordinating is important. As the previously said, that need to know where everybody is, or everybody needs to submit where they are, but the coordinator already knows that, because previously most organizations were given areas to work in. For example, Site Savers is in Busoga and Karamoja. Okay, so I had one of your presenters earlier, your members earlier, saying that she's in Jinja, nobody could go and help her. I will not be able to go on and provide services in Jinja because Site Savers is the one providing services in Busoga. So there'll be duplication, and there's already a partner there.
True.
Okay. So some people have been asking us, can you come and help me? I'm in Kamuli. I said, you know what? I cannot go there because Site Savers is responsible for that area. Therefore, you need to go and see Site Savers, see if they'll be willing to support your activities. So things like that. Otherwise, it's going to be competition and stepping on each other's toes. So that to avoid duplication, since you're playing a coordinating role, please liaise with the National Eye Health Coordinator in the ministry who's probably one of your neighboring offices there. They know where we are. As the Alliance, yes, if people have become members, then they should be able to provide you with information of where they are working, so that you know that, okay, this area is already covered. We don't need to go and take an outreach there. Okay, you don't need to come to Rende because I am there. I'm already doing some work there. So you can go to Luero, or you can go to Nakasongola, or different district. So I think that is very, very important when you're providing these outreach services. That has been a weakness. Most districts don't have funds to support those activities because, as they mentioned in the National Eye Care Plan, the districts don't have eye care services integrated into their health services. So that's one of the weaknesses. So what we are trying to do is to make sure that when we go in an area, we support the district and strengthen the eye care services in that district. Okay. So hello, can you still hear me?
Yes, we can hear you. Please go ahead.
Oh, okay. Yes. So those are the things where you might find that a partner might come in and say that nobody was willing to support them, but you might have come to a partner who cannot work there because somebody else is already there. Okay. So if you're doing a standalone camp, then you know that you also need to liaise with the eye care providers in that area, because once the camp is over, they're the ones who are going to be doing the follow-up after you've gone.
True.
Okay, so again, that's one of the challenges we face with standalone outreaches, in that once the outreach is over, then there's nobody there to follow up on, especially if they are surgical, to follow up on the services. Some of our areas are much simpler. You give a pair of glasses, etc. But the surgical services, you need follow-up. So you need to have an OCO if you're in a district level who you're working with. So the team that comes from Mulago needs to liaise with a local OCO who's there, who is going to follow up on the services after that team has gone back. Otherwise, you're going to leave patients stranded.
Yes.
We work a lot with children. Our organization is involved a lot in child eye health and school eye health. So when we go in there, we're now trying to link between health and education. So in the districts where we're working, we are creating a linkage and strengthening the linkage, if it is already there, existing, between health and education sector. Teachers don't know where to refer children who they've identified with problems. Healthcare workers also get the children, but then the teacher is not informed that the child has got visual impairment or the child has got this. Those are the other things we're trying to work on. So there's a lot of linkages that are needed, a lot of, as they call, system strengthening that we are supporting the ministry with. So as you have some partners who are coming in and doing outreaches, you also need to work hand in hand with the partners who are doing the sustainable kind of services where they're strengthening the systems and seeing how where they're putting something that is going to continue going on even after the partner has exited. So again, those are kind of things you need to look at. So there are multiple entry points, and each partner will come and give different things based on their strength and based on their members. But you as a coordinator now need to know how to play these strengths and how to build up on everybody's strength to see how you can build a whole holistic eye health service to support the Ministry of Health and the government of Uganda. So that's what I was looking at. And going back to the presentation of Mr. Kaggwa, he talked about the HMIS. For eye health, the ministry has adopted the IAPB database. We supported the training at the national level. I think Site Savers is supporting the training from the regional down to district level. They've been going around the country. So HMIS already has a partner supporting it. The health promotion material, when you came to that workshop we hosted, those are one of the teams we had. We need to work with Mr. Kaggwa's office to see how we can build up on that. Again, everybody's going to come with their own materials. We need to find out to consolidate it and have a database. Things like that. So basically it's coordinating, but at the same time consolidating the strength of the partners, but in partnership with the Ministry of Health and the National Coordinator's Office.
Thank you very much, Naomi.
Thank you very much.
Could I?
Yes,
could I just?
Oh, Denise, please go ahead.
Yes. Dr. Naomi, I concur with everything that you've said. I'm the lady who found the children in Ginger through Sebastian. And we found, we had a list of children, children from villages. Sebastian found them, but there seemed to be nobody that owned these children in terms of, in the UK, we would have GPs or health visitors who would know about the children. And from this list, we tried to find out pathways for all these children. We had one particular child who needed corneal grafts, and he went to a private hospital where one of his eyes has now been treated. But exactly what you're saying, it wasn't just a one-off occurrence. He had to keep going back and back and back for tests and follow-up treatments. And we found a charity was having to pay for the transport and overnight stays. And there seemed to be a lot of money that just gets lost in the process. Mm. And I mean, you're so right in that it is about coordination and at that smaller level, because my thinking is if these children in Ginger had like an eye shop to go to where they were tested, some would have the glasses and drops. There would then be pathways for them to go and have the cataracts operations. Those that were more complex would go somewhere else. And I think it's looking at how you manage all this. And also I do like your point about linking up with the schools, because we're primarily an education charity, and we've come across quite a few of these children because they can't go to school, because they can't see the blackboard. So this is what's, you know, motivating us to get these children, their eyesight as good as it can be, and get them back into education.
Okay.
Yeah, that is true. The children have been left out completely when plans have been made for most of these eye camps and outreaches historically. We've just completed the Child Eye Health Project in December 2016 for East Africa. And this is where we had all these learnings of the lack of systems, the lack of linkages. Disabled children are not in schools. We found out we were looking for them in schools to give them glasses, to give them low vision devices. They were not there. They're at home. You know? So now we started working with the districts and the probation officers and the community development officers, people we never knew existed.
Yeah, we are in the process of revitalizing our school health program, but I also want to observe and realize that among the activities, eye care is not coming out very well. I think the next meeting shall have a school health meeting together with education and gender. I think we should do that agenda. I think I'll push that agenda on, so that because they are looking at immunization mainly and some other services, but eye care has not been.
So again, we linked with the district education office, the inspectors of schools, the CCTs, the center coordinating centers where the tutors are, and that was our meeting point. Because each center serves several schools. That's where the teachers get trained. So that's where we train the teachers, and that's where we took the eye care worker and asked the teachers to bring the children to that point. So we took the services closer to the children.
Yes, that's exactly right.
So, we don't have an NHS system where you have a GP and your GP is there for life and the whole family goes to that. No, here there's a lot of doctor shopping. People have their little exercise book, which they move with wherever they go and get services, and everybody writes in that book and they move with it. So it's not the same system that we have outside where your records are kept in a health unit, and every time you go back there, they'll just pull your records out and follow up. No, here the patient moves with their record. You know, you might not be able to find it in the hospital, but you will see them moving there. There's exercise books, and you write in that as well and do that. So it's a very different system from what we have with this. But then you have to find a way, how do I work with this system that exists in Uganda? And how do I get services, especially for children? Because they are minors, they cannot come on their own. Somebody needs to bring them, or you need to go and find them. And adults will find their way to the outreach camp, but we'll find that with outreaches, children don't come. It's the adults. And that's why you get all your cataract surgeries and everything, but you're not going to find children there.
But I think
children, you find them in schools, and that's why we've been trying to integrate eye health into the school health program. So we're trying to get, with a lot of fighting, to get the teachers to help us. There are more teachers than healthcare workers. There are a lot more teachers than eye care workers. So we're asking them to screen, and then we're trying to find a way of that. All those children who fail, how do we reach them? And that's basically what most of our projects have been doing, even up to now. We've integrated that into all our comprehensive eye health projects. So, like I said, the role of the Alliance now is to look at some of these things here. Some people will be working with adults, but then there's a big population, as you know, 50-60% of our population is under 15. There's all those guys. And how do we get services to them? And then the little ones who are visually impaired, who need even more expensive devices.
Can I come down to that?
Projects, we are able to provide those devices. Sorry?
Sorry, Dr. Naomi. I just wanted to add to that when you finish. Sorry.
Oh, okay. So that's saying that we as an organization, as we are willing to provide low vision devices for any child in Uganda, even outside of our project areas. If you find a child who is visually impaired, anywhere, you let us know. We will provide a low vision device for that child. We bring them in for our project areas, but we serve the whole country so that we don't limit it to our project area. Even if you find very poor children who need glasses and can't afford, because some other NGOs charge for those glasses, we will try and provide glasses at no cost through our projects, because we're specifically working a lot more now with children. We also have our Children's Vision campaign, again, which is supporting children, especially those below 15, but all children, and we provide them with these devices at no cost, because most partners don't know where they are, can't find them, or do not have access to them, or don't have the eye care workers who are able to examine the children. We know where they are, and we have access to those things, and we're willing to share and provide them to anybody in the country.
Good. Good. Thank you. Thank you.
Thank you. Yeah. Quick addition to that, Dr. Naomi, thank you so much, because that provides a sort of pathway, a screening pathway. The other thing I wanted to kindly add, while we've got the Uganda UK Health Alliance executives and Minister of Health, we don't seem to have any clinical leaders. Mengo, for example, or Mulago or Mbarara, who are on board with us continuously. I think kindly Denise has made a relationship with Mengo, who've been able to help, but sometimes you then don't hear back. So we kind of wanted support from the top team to just engage those 3 hospitals who provide services, and also find out what services do they provide. For example, you recall the little girl that died. I checked with Mbarara, and apparently they do an ocular tumor pathway, but they only do it up to the ages of 5 years old. So where do the children over 5 years old go? And I think that adds on to what Denise is kindly raising, is what do these 3 key eye institutions, what do they provide? That would be really nice.
Yeah, I think you find that for pediatric services, yes, you have Mengo, Mbara, Benedictine, and Mulago. When we work with them for projects, the Mengo, Ruharo, and Benedictine are not free. You'll find that you might have to either come up in an agreement and they give you basically a cost per surgery, or I think that's the way they work out. So that's one of the challenges. Mulago, obviously, is government, and Dr. Salis, who's been working with you, for them, usually once a child is brought to the hospital, they provide the services. But yeah, those are some of the limitations we have, in that we really don't know exactly where the limits are. There's not really any clarity from all of them. You have to actually go engage with them directly. So if the ministry can assist there, it would be good, because otherwise when you go as a private entity, an NGO, whatever, then people look at you differently. Obviously, they expect you to be coming already with some project funding, and sometimes you don't, you don't have the funds. So those are some of the challenges. And even for us, some of our projects don't include surgery. So if we identify children who require surgery, we are stuck in where we send them, because if we send them to Ruharo, they will ask them for a fee, which obviously they cannot afford, and then they just go back home. And what you experience, I experienced it in Mbale. We identified the child with glioblastoma in Mbale. We asked the mother to come to Mulago to bring the child. Dr. Grace offered to do the surgery for free. But the mother went back home and said, well, I can't leave my other children there. I don't have any support. I can't move with one and leave all the others. And we lost that child. We don't know what happened to that child. They never came for services. So things like that where, we're still trying to figure out how, especially in those cases of cancer, where how we can get these services to the kids and get them taken care of by someone and somebody else to support the parents, because culturally, as a woman, you cannot just leave your family behind and just take one child and be there as a caregiver for weeks and weeks and leave the children at home. So they're also stuck, and it's very frustrating.
Okay. Well, I appreciate actually all your contributions. This is seems quite interesting, though the time is actually not on our side. And I think I would want us to move forward. Yet we've had these discussions and we've identified that there are quite a number of gaps that need addressing. And Dr. Noami, I appreciate you for giving those insights and enlightening the team on some of those things that the team didn't know. But I think we are at least at par now with some of those things. And we are looking forward to more of these interactions with the team so that everyone gets to know where to find what, how to do what. Because you are the experts within the area. The Uganda UK Health Alliance, like you've known it and you've emphasized it, we are doing this coordination role and seeing that, all these partners come together, do communicate, and then see what they can deliver all together. So I want us to do a bit of conclusions here as a team, and moving forward, we need to look at the next steps. And one of the things, having identified all these gaps and seen some of the solutions that have been provided by some of you, I think moving forward, we can say that some of the conclusions I'm making from this discussion is that we need this forum, this communication platform. We need to have a sharing platform, and you can see that through this sharing we've had a lot. We've shared a lot of learning, and I believe joint working is going to be what is going to be the offspring of what has happened today. So moving forward, we are going to create a sub-COP, which is a mailing list where we shall exchange, and we will encourage everyone actually to share what you have, something that you think that is going to benefit the rest. Ministry of Health, we shall be actually always liaising, like Dr. Noami has mentioned. We've always been in constant liaison with the National Eye Coordinator, that's Dr. Stanley, and we want to continue actually now being more focused, more specific on some of these issues that we've identified right here, so that we get to guide the rest of the partners within the consortium right. Then we shall do quarterly webinars. I don't know what everyone has to say about that, and I would request that we have, if that is what we are agreeing with as a team, we try to block our diaries, those dates, and I think we should agree on the next webinar. The next webinar, in fact, we should agree on it right away. Because today is we are in January, and if we are to have another webinar, good enough, we had actually the first one in Jan, so quarterly will be very easy. So can we have another webinar shortly before 22nd, around in March? Can we have it in March, around the same date?
We've got the convention.
Or in April?
Yes, April will be better, please.
Yeah, can we agree on a tentative date that if, so that everyone gets to know? April, can we have it on, we usually prefer Thursdays. Can we have it on Thursday, 5th April? I don't know if there's anything major there on that date. April 5th, what does everyone have to say about that? Terry, Isaac, Denise.
Yeah, that works well for me.
I'm happy with that date.
Okay, 5th April. Terry is happy with that. Isaac is okay. John Paul. Denise.
Yes, thank you.
Are we okay with Thursday, 5th of April, having our follow-up webinar?
Yes, that's fine.
Yeah.
Great,
Thank
great,
you.
great. Thank you. So we take 5th April as our next call, 2018. So we shall have to share our developments. And then the other thing is that we've not yet agreed on, Dr. Noami has told us that we should liaise with the National Eye Coordinator to map out the other partners in all the regions who are doing eye camps. Yeah. So Primrose, are we at part with that?
Yes, absolutely. Thank you.
Okay, so we are going to try our best to liaise with him. When he's back, we expect him on 31st. He would have been with us on this call right here, but it's unfortunate we couldn't have him because he's on leave. We expect to do the liaison maybe by 31st. Oh no, let's give ourselves the first week of February, and that will be between 5th and between 5th and 10th. Yeah, between 5th and 10th of February, we hope to talk to Dr. Stanley, and we hope to bring feedback about where everyone is working. Okay. So that will help us on the mapping, and I think we shall agree on the ICAMP schedule after that, when we have liaised with the coordinator. And moving forward, I think also, of course, there have been some concerns that have been addressed, especially Denise's issues by Dr. Noami, and those have been taken note of. And then in conclusion, we shall share this video with everyone on our YouTube platform. You will be able to access it. When we share it, we shall share with you that link, and then also the resolutions that we've made for today. Except if maybe John Paul has something to say on the side of the Alliance. That's all I have to say.
Not too much, Henry, but it really goes to the partners who have taken part in this call. Primrose, Dr. Noami, Denise, Terry, Mr. Ddumba, and still we have the summit coming forth in March. In constant discussion with the public-private partnership for health office regarding how we can really partnerships between the private sector and the public and the private sector. The March summit is very important, and they can have representatives from the organizations on this call come forth, because we have deeper discussions still on how we can have the Uganda Eye Institute established. As Ian mentioned, that many of these initiatives, but as also Dr. Noami, you did mention aspects of a strong joint force. So all we are doing is contributing to universal health coverage, contribute a system that we want to see our country have, and of course learning from the other systems that have excelled significantly as far as what you're doing. I really think that through this sharing, through the platforms that we shall try creating, we shall move from one step to another. And of course, advice and guidance from how we can better joint working and co-develop amongst partners to reduce duplication of efforts, but also increase on the impact of the resources and efforts that we are putting into the sector. Thank you very much, Henry, for putting together this call. And we look forward to joint working with all the partners in the Eye Health Consortium. Thank you indeed.
Thank you very much, John Paul.
Thank you.
Any remarks from anyone that you think we've forgotten, especially the resolutions? we are happy to, someone can mention any, can close. Yes? Somebody was saying something?
Yes, please. One more.
Yes, Primrose.
Yes. One more question.
Please go ahead.
On what Dr. John Paul has mentioned something very critical, the private-public partnerships. Now, are we happy to let the private partners hold camps as they wish? And obviously we can just support them. Or do we all hold the same camps as agreed by everybody?
Right now, as we speak, camps are regulated by the Ministry of Health. Not anybody can just hold the camps without clearance from the Ministry of Health and Uganda Medical Association. So dental practitioners, association and the council. So we need to be aware of that. It's not anybody to come and make camps. They are regulated now by Ministry.
Dr. Noami, do you have anything to
just to add on to that? I'm sorry. Yes, any team that is coming into the country to conduct a camp needs to get a temporary practicing license from the council. That involves medical doctors, obviously go to medical dental. Any optometrists have to go to Allied Health. The Optometrist Association can support, or if you go through me, I can link you. Basically, we vet, because we don't have a regulatory body yet for optometrists as such, but we're under the Allied Health Council. We vet optometrists, opticians who come in. I'm trained in the US, I can vet for the US. Mr. Dwalega is trained in the UK. You can access the GOC, the General Optical Council in the UK, and vet those. Then we advise the registrar accordingly. And then, like I said earlier, that to make sure you link with a local eye care worker in the health facility in the area where you're working so that they can do follow-up. But we also liaise back with the National Eye Care Coordinator. Everything has to go through ministry. And this goes back to the whole mapping thing as well. But they have to get temporary practicing licenses.
Thank you very much, Dr. Naomi. Primrose, I think that answers the question very well. Dr. Naomi has put it rightly, and I think I can't make it any better.
Thank you.
You're welcome. So I want to appreciate everyone who has attended this call. I know we have a lot to speak. Even if we say we want the whole day and night to speak and talk about eye care because we are all passionate. But I think the time we set to have this call is almost done. And I want to appreciate you and to encourage you actually to continue being part of this fora and discussion more. We'll be very happy. It's unfortunate. Isaac, we didn't really hear anything from you. Isaac, I just want to give you an opportunity to speak to the team just briefly, and then we close. We didn't hear Isaac. Isaac, please.
Yes, I apologize for the poor connection, but I'm so honored to be on this call with like-minded individuals that have a concern for the eye health industry sector within Uganda. I started the Eye Care Foundation because of my own issue with my vision. I'm clinically legally blind. I've had 2 corneal transplants, and working with Dr. Henry and Primrose has been an honor to me to find other like-minded individuals where we can consolidate our contacts, consolidate our resources to put across more health camps around Uganda. So I would love to learn and assist wherever I can on us advancing the eye healthcare sector within Uganda and East Africa as a whole. So I'm honored to be here and happy to learn.
Thank you very much, Isaac. And right after his communication, I want to say thank you very much for all your submissions and contributions. And I think we shall support the National Eye Health Plan like we've seen. And in the next 5 years, we shall support the targets that we saw. Thank you very much, everyone. And I wish you a nice evening and the rest, actually the weekend ahead also.